Hello and welcome to Health Equity Teachers video on refugee and immigrant health. This is the first video of a two-part series, and let's get started. As always, here are the learning objectives for this module. Define the terms refugee, asylee, and migrants. List and describe disparities in healthcare access experienced by refugees and immigrants. List and describe health issues and factors that impact the health of refugees and immigrants. Describe how to find clinics and care centers that may help refugee and immigrant patients. Identify important aspects of the visa medical exam, the initial domestic screening visit, and migration history for new refugees and immigrant patients. And apply culturally sensitive care and cross-cultural communication to the care of refugee and immigrant patients. I want to start off by defining some terms that are used to describe people who live in the US now but were born somewhere else. First, an immigrant is someone who leaves their country to settle permanently in another country. An immigrant is someone who lives permanently in a foreign country. And for the purposes of this module, immigrant will refer to someone who was born outside of the US but now permanently lives in the US. A refugee is a person who applies to come to a country, and again, for the purposes of this module, will refer to someone who came to the US to flee persecution due to race, religion, nationality, social affiliation, or political opinion in the country that they were originally from. Refugee status then is a form of protection that's granted. An asylee is someone who comes to the US and is unable to return to their country of nationality or seek the protection of that country because of persecution or fear of persecution. A migrant is someone who moves from one place to another, so that can be within the borders of the same country or across international borders, and this is usually to find work or better living conditions. The movement is usually temporary, and this is in contrast to immigrants who have the intention to live permanently in another country. There are also foreign nationals, who are people who have visas to work or study abroad. And again, they do not have the intention to live in the US permanently. And so these people are not considered immigrants. So hopefully these definitions clarify some terms about people who are in the US now, but were not born here. So now that we have defined some terms related to immigration, let's discuss immigration in the United States. Here are some demographics and statistics. Since its beginning, the US has been known as a land of opportunity. Most of the US, somewhere around 99%, are descendants of immigrants at some point or are themselves immigrants. So the US really is a country of immigrants. The number of immigrants has quadrupled since 1965. Currently, about 13% of the US population is foreign-born, and that ends up being around 41 million people. And about a quarter of the US population is either first or second generation. This means that about 80 million people are immigrants or children of immigrant parents. The 5 countries with the most immigrants in the US are Mexico, China, India, the Philippines, and El Salvador. In the year 2000, Hispanics made up 48% of the immigrants arriving to the US, and Asians made up 22%. However, these numbers are dynamic. Around the time of the 2008 recession, immigration from Latin America slowed. And by 2055, Asians are projected to be the largest immigrant group in the US. About 77% of the immigrants in the country are here legally. And there has recently been a decrease in unauthorized immigrants as well, at least in part due to policy. So that leaves about a quarter of the immigrant population that's here not legally. Legal status, as we will talk about, can have a profound impact on health as well. Now, in terms of refugees, which are again a subset of the immigrant population, in 2020 there were 11,800 individuals who arrived as refugees from Africa, Asia, Europe, and Latin America. Immigration policy determines who can legally enter the US. Before 1980, the refugee policy was heavily influenced by the Cold War and communism. So coming from a country whose government was communist was enough for refugee status. The Refugee Act of 1980 based refugee status on evidence of persecution rather than ideology. Nevertheless, the president can make exceptions, and the president and Congress together determine the total number of refugees to be admitted to the U.S. In 1996, the Illegal Immigration Reform and Immigrant Responsibility Act tightened border restrictions and changed rules on immigrant access to public benefits. Over the past few years, there have been a lot of changes in policy and enforcement of those policies. There have been travel bans, DACA expired, there's been changes to border enforcement, there's been changes in asylum rules, and a shift in deportation priorities. There have also been changes in what is called the public charge rule. I want to touch on this because this rule affects why people do or do not use public services. The public charge rule is the rule pertaining to immigrants who are likely to become a public charge, and they may be denied visas or permission to enter the country, or denied application for lawful permanent resident status. And as of February 2020, the public charge is now defined as an individual, receiving one or more public benefits for a period of 12 months during a 36-month period. So those who are not yet permanent residents may choose not to use public resources such as food stamps, health coverage, etc., because of the way it may affect their residency case. Additionally, I think it's important to mention that many of those coming to this country have come to work, and so this applies to both legal and illegal persons in the country. New immigrants formed about 50% of the new labor force and are thought to have provided a net economic gain for the U.S. economy. And the jobs and work that immigrants do is also very diverse. Now let's move on to talking about access to healthcare for those who are not born in the U.S. There is this very common misconception that immigrants overburden the healthcare system. However, research shows that immigrants use public resources at lower rates than those who are born in the U.S. Immigrants are also more likely to be uninsured. For refugees, they have an initial 8 months of health insurance covered by the refugee medical assistance, but after that, they're often without insurance and have a lapse in coverage and care. Additionally, asylees are not offered the same 8 months of insurance, and those who enter illegally often do not have health care insurance at all either. Immigrants use medical care, dental care, and emergency services less than U.S.-born people. And this can be for a number of reasons, such as cultural ideas of care, social economic factors, family structures, and jobs, among many other reasons. Overall, there is inadequate care. Immigrants have lower rates of health insurance, less healthcare usage, and lower quality of care. Culture can play a role in accessing healthcare as well. There may be distrust of the healthcare system because of their experience with healthcare in their home country, or because the system is foreign. There may be issues with continuity of care and adherence, as in some cultures, you only go to the doctor when you're sick or for acute matters. And so follow-up cares or visits when the patient isn't feeling ill, they aren't customary in many places. Also, issues surrounding spirituality and religion. This plays a role, and it can affect when it is or is not appropriate to seek care, or even who the patient can see for care. And this plays a role especially in regard to gender. Additionally, depending on what medicine is like in the immigrant's home country, they may have a preference towards alternative or complementary medicine as well. There are many health issues facing immigrants, including risks of the home country, so the country the patient's from, the new country, so in this case again it's the US, and the journey between the two. In the home country, risks include trauma, environmental exposures, infectious disease, and genetic susceptibilities that are common in that region. During travel, there are legal, medical, and psychosocial risks, and once the patient gets to the US, there are new exposures and lifestyles. In addition, they're navigating a new legal system and a new health care system, and this can really affect health as well. And so these risks often present as diseases that providers need to screen for. Communicable diseases are more common in the immigrant population than in the general population, including infectious diseases such as TB, HIV, Hep B and C, and malaria. as well as dermatologic, GI, and respiratory infections. Experts recommend that physicians have a low threshold to screen for chronic illnesses such as hypertension, diabetes, dyslipidemia, because they often present at younger ages in immigrants. Additionally, depending on where the immigrant is from, there are areas of the world with elevated lead in the blood, and so this is particularly important for children. Physical health issues aren't alone. There are also mental health issues, and these are associated with immigration and life here in the US as well. Mental health concerns are one of the most common medical problems seen in the primary care setting. There may be different cultural contexts or conceptions of mental health as well. In some countries and cultures, mental health does not really exist. Researchers have found that there are high rates of anxiety, depression, and PTSD in the immigrant population. PTSD and depression rates may be as high as 30% in the refugee population. Trauma and torture also affects immigrants and can have a severe impact on mental and physical health. Migration itself is a stressful and traumatic experience, and going back to the risks of the new country, there are a lot of challenges and stressors that can occur post-migration. And so some of these include new exposures, new systems, and really a whole new life. And so mental health issues often manifest as somatic complaints, such as chronic pain and GI symptoms. In terms of immigrants and refugees, especially given the cultural context, it's really less about an accurate diagnosis and more about determining who needs added support. Furthermore, there are special issues that may impact the health and healthcare of immigrants. Most immigrant communities have close family relationships, and these serve as support. During immigration, oftentimes there are fractured relationships and family divides due to visa issues, immigration problems, and other circumstances. Other family structures, especially expectations, may also place strains on immigrant persons and families. Acculturation is the process of adapting values, customs, attitudes, and behaviors of the mainstream culture, and this can create conflicts, especially related to intergenerational pressures. There may be differences of perspectives on issues such as sexuality, gender roles, marriage, and elder care. Sexuality, reproductive health, and somewhat consequentially HIV and sexually transmitted infections may be particularly difficult for immigrants. Female circumcision, which is practiced in many African countries, is much more dangerous than male circumcision, and it has both physical and psychological sequelae, including gangrene, sepsis, Women who have undergone this procedure may be reluctant to seek medical care or mental health care because of fear of stigmatization. And again, culture may come into play as well. Depending on the culture, seeing male doctors or talking through a male translator is not allowed, especially when it comes to sexual health care. So that's something to be aware of. Immigrants may have been exposed to violence in their home country, but due to poverty and other factors, they may be exposed to violence and crime in the US too. Immigrant women have been reported to be an increased risk for mortality and domestic violence. Hispanics have higher rates of death than whites here in the US as well. Factors such as fear approaching the police or with the judicial system, or even inability to access these services, as well as language and information barriers, can amplify these issues. And then additionally, I want to touch on border health. A lot of people, nearly 12 million people, live along the Mexico-US border. There are issues with air quality, water quality and quantity, and many other issues there. There are higher rates of infectious diseases such as Hep A, Salmonella, TB, and more. People residing in these border regions often cross back and forth to get healthcare from either side, and so interventions are harder to coordinate and harder for patients to receive as well. Legal status can have a huge impact and exacerbate many of the factors we discussed. There is overall a profound impact on health. Lack of legal status can be a barrier to health insurance and accessing care. Some fear being reported to Immigration and Customs Enforcement, or ICE, and being deported. And when undocumented immigrant patients do get care, they often receive lower quality of care. The fear of being deported has also been linked to what is called toxic stress in undocumented immigrants, leading to poor physical and mental health. With that being said, inquiring about legal status requires a lot of sensitivity. Legal status is not required to be and should not be documented in a patient's medical record. And as a physician, you are not obligated to speak with ICE officials. Just remember that asking about or discussing legal status is a really sensitive subject. Okay, and that concludes this video on refugee and immigrant health. If you have not already done so, please watch the second video in this series on ways we can better care for our immigrant patients. Thank you.